This is our last session, and it focuses on precision medicine, as I told you earlier, and the future of healthcare. So we are honored to have here Mr. Antonis Armoundas, who left Greece in 1991, went to the States, and now he's here with us after a career in just in Boston, Harvard, and Massachusetts, right? Okay. So he's Associate Professor of Medicine, Harvard Medical School, but also he's a Principal Investigator, Division of Cardiology in Massachusetts General Hospital. So thank you very much. And he's going to be interviewed by Vassilis Papakonstantinou, partner and head of technology for Blue Dome Capital. So please welcome them. Thank you very much.
Margarita, thank you very much all of you for being here. Good evening. I would like to thank MIT Technology Review and Kathimerini and my good friend Vassilis Papakonstantinou that invited me to be here today. The talk today involves precision medicine and a journey to achieve precision medicine. I'm pro artificial intelligence, but I'll try to present a pragmatic and grounded approach in that journey. So today's talk will include a description of precision medicine and precision prevention. I'm going to talk about bias in clinical research, algorithmic bias, a case study in cardiology, where I'm going to talk about the role of artificial intelligence and data interoperability in cardiology. I'm going to try to present the current regulatory framework in the United States and the EU. I'm going to describe rather superficially the role of social determinants of health in artificial intelligence algorithm outcomes. And I'm going to close this talk with the case of using artificial intelligence in Greece in healthcare. So when we talk about artificial intelligence, we have to keep in mind that we're trying to, this is artificial intelligence in healthcare, and we want to promote healthcare and equity for all. And it's good to have in mind the World Health Organization's this quote from the World Health Organization, that there is no equity in the absence of avoidable, unfair, or remediable differences among a group of people, whether the groups are defined socially, economically, demographically, or geographically. So the American Heart Association has seen artificial intelligence and technology as with an integrating functionality, where they state it's important that existing information is brought together to facilitate the generation of new findings in the basic and clinical research communities. So what do we know today is we know that we're all different. We're all coming with some predisposing risk factors and eventually develop disease which is manifested in a different way in each one of us. Yet and therefore we have a differential biological response in treatment. Yet when we treat individuals, we learn to treat the mean of a distribution. So what we want eventually is we want to be able to treat each individual at its current state and bring it back to an early state of healthy being. So here is we talk about precision medicine, which involves precision diagnosis and treatment, but eventually we want to move to precision prevention. And the journey to precision prevention is a journey in time, where as time goes by, the disease burden increases as well as the cost. So we want to, early on, to assess the baseline risk that I mentioned earlier through earliest possible molecular detection of the disease and intervene at that time to prevent that phenotype that we will have to treat later in a much more aggressive way. So fundamental in this process is the issue of trust. It takes lots of time to build trust, but very little time for that trust to go away. So trust is a key issue of my presentation today and how we're going to maintain that. So a key component in this journey is data, big data, and three aspects of data are important in this process. The data have to be clean, they have to be well annotated and unbiased. The issue of clean and annotated data, I think it's obvious to everybody. I'm going to talk a little bit about how data can be biased and what are the implications of that. So bias in data in clinical research may appear in any number of steps. It can be in the design step, where you may have gender or age-related bias. It may appear in the conduct of the study with measurement bias, social bias, in the analysis of the data, where one sees future selection bias, missingness or imputation bias, training and validation bias, or in the interpretation and dissemination, which each one of them involve different types of bias. So what is the effect of that? The effect of that has been that we have seen high-profile cases of either technological or cases in the healthcare with adverse outcomes resulting from biased algorithms. So what is algorithmic bias? Algorithmic bias occurs when the application of an algorithm compounds existing inequities in socioeconomic status, race, ethnic background, religion, gender, disability, or sexual orientation to amplify, adversely impact equity of health outcomes. So this is very important to keep in mind, and because that will be one of our guiding principles in this presentation. So the American Heart Association, a few years back, put together a task force that I had the privilege to be part of it to establish principles for data collection, sharing, and use. And the principles of that statement, of that policy statement, are, first of all, it involves the funding organizations, the medical scientific research communities that should prioritize and support research that is generalizable to all and specifically designed for historically underrepresented communities. Entities that collect health information and researchers who use it should be held to the highest standards of behavior, including being respectful of the people from whom the data are derived, and being responsible stewards of the valuable common resources. The third one was that entities that collect health information and researchers who use it should be transparent about the potential and actual future uses with patients and other data contributors. Number 4, awareness, education, and involvement of patients of minimal risk research are encouraged to enable important future discoveries. Number 5, medical and scientific researchers, research institutions and publishers should commit to making health information derived research findings and innovations widely accessible to all. And number 6, federal law should provide a consistent baseline of protection and enforcement of individuals whose health information is collected and used. Subsequently, the American Heart Association put forward a statement which I had the privilege to chair about AI in cardiovascular disease. This statement has explored the issues regarding patient safety and data protection, bias and fairness, accountability and reliability, regulations, cybersecurity and upgrades, clinical decision making in all aspects of cardiovascular diagnosis and treatment, including imaging, electrocardiography, bedside monitoring, molecular diagnostics, genetics, and electronic health records. An important component in the process of developing, incorporating technology in the future of healthcare is data interoperability. Here, in another statement by the American Heart Association, the role of ambulatory monitoring was examined on and its importance in improving outcomes for all. So the central theme of that statement was a number of devices that are used today, whether it's these are a phone or a watch or glasses, are used to obtain novel measures and metrics which are either entered into the HR, but importantly, they have to go through regulatory oversight for a number of reasons. First of all, we want these devices to be accurate, and we need to select which devices will enter into the clinical pipelines. We need these devices and the outcomes of these devices to be integrated into the electronic health record framework. We need strategies to eliminate bias. We need device security and reimbursement strategies and so on. So it's a complex process when we talk about precision medicine, which involves many aspects of technology. So more recently, we tried to think about all aspects of data that may involve precision medicine. So that journey starts with digital object retrieval using traditional approaches like the electronic health records, standard electrocardiography, monitoring, imaging, molecular biomarkers, from where we obtain a phenotypic and molecular that involves phenotypic and molecular data acquisition. These data have to be harmonized and standardized. Then a digital object retrieval follows, molecular signatures are extracted, analysis and interpretation of this data follow, and then all this is synthesized and integrated into hypotheses which are coming to reinforce phenotypes, and this process goes on. So again, I'm going to come back to the issue of trust. These processes have to be in a way which is respectful and enhances and builds trust for all stakeholders. So the approach that in the United States has been followed to maintain that trust primarily is enforced by the FDA. And here is the FDA's total life cycle artificial intelligence approach that starts with planning and design, data collection, model building, verification and validation, model deployment, operation and monitoring, and eventually real-world performance evaluation, continuous performance evaluation throughout the life cycle of the product. This approach that employs software as a medical device has led to an exponential growth of devices and technologies that use artificial intelligence the last few years, and that growth is expected to be even higher this year, and is based on principles that eventually aim to foster collaboration to safeguard public health, advance the development of regulatory approaches that support innovation, promote the development of standards, guidelines, best practices, and tools for medical product life cycle, and finally support research related to the evaluation and monitoring of AI performance, continuous AI performance. So, however, the global landscape continues to evolve, despite the fact that the United States policy and policies around the world actively are trying to develop guidance and frameworks to address rapid advances in AI. Still, the main focus in developing guidance and principles, and very recently approaches, the interest has been generated to lead to international collaboration among countries that would help develop a global nature of AI development and deployment. Eventually, a need has been established for potential legislation at the global level, yet in all these approaches, we do have a lack of enforcement and deterrent on the inappropriate use of AI or any AI-used technologies. So, in that background, following the EU AI Act, to address the opportunities and the challenges of AI in Europe, 5 universities, prominent universities in the United States: Vanderbilt, Duke, Advocate Health, University of Texas Southwestern, and Northeastern University, together with Microsoft, got together in November 2023 to develop the trustworthy and responsible AI network. Today, that network that was launched in March of 2024 lists 50 institutions that combine both the academic and the industrial world. And eventually, the aim is to promote AI in healthcare across across society, across all people. So, what's important to realize, though, in this journey is that what do we know today is we know that the life expectancy of people depends on their zip code. So in the United States, if someone knows if you can give the zip code to someone of where they live, one can determine how long they're going to live. So we went ahead and tried to understand the impact of social determinants of health in cardiovascular disease, and that's a paper that was published a couple of days ago. And we identified a few factors that contribute to adverse outcomes relating to cardiovascular disease, and these have to do with education and education access and quality, healthcare access and quality, neighborhood environment, social and community content, and economic stability. So when we talk about AI algorithm development and precision medicine, it's imperative that we consider factors that inadvertently affect outcomes. In a recent paper that was published, it's about to be published, it was accepted in Nature Reviews Cardiology. This is a consortium of authors from all over the world, 6 continents, except Antarctica, that I had the privilege to co-lead. We took into consideration the effect of access to digital healthcare as a determinant of health outcomes. And we identified a number of factors that affect this access, and primarily starting with industry, involving government, healthcare institutions and non-profit organizations, community and society, interpersonal and individual factors that contribute to digital literacy and access to healthcare. So this is another factor that affects outcomes indirectly through the level of access individuals have to digital health technologies as they become more prevalent in our healthcare systems. So what do we know today is we know that individuals from vulnerable populations, including those with low socioeconomic status, psychosocial issues, immigrants, are more likely to visit multiple institutions for their care. So it's important to, as we follow these patients in time, to integrate all of their care into one system. This is the approach that we took a few years back in Boston, in my laboratory. I'm going to try to present a bit of our work. Vassilis told me not to go too technical. So this is a case study where we integrated data from 9 hospitals. That accounted for close to 2 million patient data, going back to 50 years. We de-anonymized the data, and we were able to create a platform where every patient could be observed in time, irrespective of which hospital he or she was treated. Eventually, our goal was to use this data to apply AI algorithms to predict outcomes. Here is a case study, again, from our group, where we tried to see whether we could identify signatures of the electrocardiogram that would allow us to distinguish between black and white individuals. This is unpublished work, and hopefully we will see it in print soon. So we were able to see signatures in the adult population. And when we asked the question, where are these signatures from? We went back to pediatric data. We went we looked into data from 0 to 18 years old, and we found out that at birth, there are no differences in the electrocardiogram between blacks and whites. Those differences appeared in the age of 15, 16. And then the next thing we did is we looked at the zip codes of where these individuals lived to assess their socioeconomic status. And what we saw was that the individuals with low income, their electrocardiographic signals, whether they were black and white, they were similar. So clearly, we have the impact of social determinants of health on otherwise healthy individuals manifested in the electrocardiographic signal. And that's a powerful indicator of the effect of the social determinants of health, but also of the need to integrate healthcare systems that would allow to follow each individual in time. So we have recently seen headlines in the Greek press questioning whether Europe is able to follow US and China in this arms race for AI. What we know is that in the fall of 2024, a group of Greek experts presented to the Prime Minister the blueprint for Greece's AI transformation. That report included healthcare, and that group identified the current state of healthcare in Greece and identified opportunities and immediate action items to improve healthcare using AI. So I'm going to finish this talk by addressing the issues of integrating healthcare into a single platform as a key step to enable artificial intelligence in Greece in the healthcare sector. And I believe the time to act is now. Complete digitization and integration of healthcare, I believe, will address health and well-being as a long-term gain, not a short-term cost, improve healthcare for all, and will dramatically reduce its financial burden to society. It will improve transparency and accountability against overprescription or medications and procedures. It will enable the creation of a trustworthy R&D AI ecosystem for and by all stakeholders. So while there is a price tag for this moonshot proposal, in the long run, the price tag of not acting or doing less will be even higher. The insurance agencies, national or private, are expected to support such an approach because it's going to reduce the money they spend for these patients. And eventually, what is needed that will promote AI in healthcare in Greece is a pro-growth AI policy and regulation approach that is accompanied by enforcement and deterrent mechanisms. So that concludes my talk. Thank you very much for your attention. Thank you.
So first of all, to remind you that you can send us your questions. We have a few minutes to discuss. So let me, you spent a lot of time talking about biases, and we've been discussing about the issue of bias throughout the day and among ourselves. So how unbiased do we think the average doctor, when he accepts 20 patients, 19 of them, they talk about a headache or a back pain and sends them to rest with an aspirin, but the 20th has a serious problem, but the bias of the previous 19 cases. So the question is, do we expect too much from the machines when we are not as unbiased as we want the machines to be?
So there is bias in all data that we have today, and there is bias in individuals, intrinsic bias that comes from our experiences and many other factors. we cannot exclude that possibility that you raised, but what we're trying to do through this process is to make people aware of these biases, whether there is a personal biases or bias in the data, and by becoming aware, they deal with these, they establish a different approach if it's an individual level, or if they work with data, they try to test for bias and use the biasing approaches to make the data more suitable for whatever they want to accomplish.
Yeah, at the level of the recovery, but the algorithm themselves cannot avoid bias overall. We aspire to, but I think we are overshooting in this regard.
We are, but we have to be aware also. So the idea is algorithms have to be, we have to know the patient cohort or the database the algorithms have been trained. That's a level of transparency that builds confidence for all that use those algorithms, especially clinicians, that they need to trust them. But also, it eventually, the more aware you become, the lesser the chances or the opportunities there are to introduce bias one way or another. A case for a biased clinician is a clinician that is not friendly to AI or technology or data science. That inevitably creates a scenario where not only the physician does not use it for their patients, but it affects negatively patient care. I think it will affect patient care negatively in the future.
Are we closing to the scenario where the patient is more demanding to have AI support from the doctor? Because when I go to visit my doctor, I will ask one of these LLMs, the advanced ones, about, I'll give some ideas and then I'll come up with some bullet points and I will go to the doctor and I have a demand. There was a discussion in a book many, many years ago, The Creative Destruction of Medicine, by the cardiologist, which I forget his name, that the users will be demanding, the patients will be demanding from. So how do you see the change of doctors in responding to that?
So information is key, and I think the patient increasingly gets empowered by having access to more technology that allows them to learn about their condition. Large language models, as you alluded, I think soon will change completely the relationship of patient-physician.
In a body or?
We have examples, case studies where two mothers that were desperate in obtaining a diagnosis for the children used a large language model. They obtained the diagnosis, they offered it to their treating physician, and that was the correct diagnosis and solved the problem. So this is still early. There are risks associated because these models are still not fully trained or fully capable to do that, to play the doctor, and there are risks of liability and understanding of what is the message they convey. But on the other hand, they provide a unique opportunity in time where the patronizing relationship between physician and patient, where physician knows best, patient has to listen, relationship changes fundamentally because of the empowerment the knowledge provides to the patient. And that's, I think, it's a very positive change.
How do you see the physicians taking that change? Like, I saw I'm a patient, I will be in favor, but what about the physicians?
I think physicians sooner or later will have to follow.
Okay.
Otherwise, they will let their patients down. Patients will become more demanding of their physicians. So it's going to take some time between a better understanding of what are the implications of that new dynamic are. But I think sooner the new generation of physicians will be data science trained, will be more digitally trained, and that will enable and make more friendly the adoption of new technologies for the basing of the patients.
So we have one question, I believe. Do you trust AI to make medical decisions, or do you believe that every decision should go through a human doctor first?
So today, as far as I know, at least in cardiology, we don't have autonomous systems that make decisions. So there is always a human in the loop. The most extreme case, the most advanced case that I heard recently was in our hospital, where CT images were fed to a model which eventually produced a report for a physician to review and correct. So this process still includes a human in the loop, and for some time it will until we reduce the error of these models to an acceptable level. We have to be mindful, though, that physicians make mistakes, make errors as well. As we present this debate, we have to be mindful and present all aspects and determine whether there is a benefit in using technology. And I think sooner or later the benefit will be obvious.
The benefit of having that as a support mechanism to the doctor, but replacing, I think, nobody will want that eventually. I mean, not as a patient. I would accept an autonomous driving car, but not an autonomous...
Well, the acceptance, I think, will come when we build trust that the technology can do it better than the physician. Once you know that the probability of a wrong diagnosis is lower with AI, then you will ask for AI. Right now, this is not clear yet. But as with every technology, it goes through a process of testing and building trust.
I would still prefer the vision of Star Trek, where the guy has this magic wand and gets the scan, but eventually he translates that to... final one, last one question from the audience. How do you think the introduction of AI models will affect other aspects of healthcare, such as pharmacies, and to what extent? Like, I assume that relates to the fact, like, the pharmacists have hard time reading the doctors or scripts or making decisions on their own, or the bureaucracy around.
So where I think maybe already a benefit, which I'm not aware, is that there are, especially for individuals that receive multiple medications, there is contraindication or reasons to be aware and concerned. So AI could easily resolve issues of that kind, raise an alarm, and make sure that there are no mistakes of that kind. There are chatbots today that remind patients when they take their medications. And obviously, there is a lot of AI involvement in drug discovery.
That's true.
Where existing compounds or newly designed compounds are expected to be generated from the use of AI.
I think it's a great way to wrap up this conference with a better future also in healthcare. We had this discussion yesterday with Damba about education. I think the education part also plays a role in the healthcare. So Adonis, thank you for
Thank you very much.
sharing.